Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus and family medicine physician at Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on diabetes. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Nahi Kiblawi, a diabetes and endocrinology specialist with Essentia Health, and Dr. John Wood, a family medicine physician with Essentia Health and director of the Family Medicine Residency program. Our medical students answering the phones tonight are Sydney Boyke of Crookston, Minnesota, Seth Kimball from Walker, Minnesota, and Lindsay Simonson of Owatonna, Minnesota. And now on to tonight's program on diabetes. Gentlemen, welcome. Appreciate you both being here.
Thanks.
Dr. Wood, do you want to tell us just a little bit about what you do and a little bit of your background as we go into the program?
Well, yeah, I'm the program director at the Duluth Family Medicine Residency program. Ray and I actually go way back. I knew Ray a long time ago. Spent a little time in Moose Lake where Ray has worked for many years, and worked in Grand Marais for many years as a family doc up there as well as other places. And I can say one thing I've seen throughout my career is both the immediate effects of diabetes, the difficulties managing diabetes, how pervasive diabetes is, and how if you don't manage diabetes, how there's a lot of downstream effects. And also how the best way to manage diabetes is really a team effort between the patient, the physician, and the patient's family and surrounding, and the patient's loved ones, because it's really a team sport to do this correctly.
How true. Dr. Kiblawi, please tell us a little bit about yourself and your background. And your work.
So I'm an endocrinologist at Essentia Health. I've been here about 8 years now. And so we see a lot of diabetes, different types of the diabetes, as well as a lot of other endocrine problems. And I have to agree strongly, it is a team effort, because we do, even at our department, we have lots of nurse educators and lots of dietitians that work with us to help our patients and to achieve the best outcomes for them.
Yeah, it's interesting. Several years ago, I realized I needed the diabetes educators. I couldn't do it anymore myself. We kind of talked earlier about what we're going to focus on tonight, and we've chosen diabetes type 2. John, what is diabetes type 2, diabetes mellitus type 2?
Well, diabetes is diabetes, sugar, basically, and diabetes type 2 is where it's a combination of impaired hepatic glucose or insulin production, but really increased insulin resistance. The insulin that your beta cells in your pancreas are making just aren't as effective as it used to be. You're making insulin, but it's not working, and it's not working because your body's more resistant to the effects of insulin. Insulin's an incredibly complex carbohydrate or complex protein, and what it does is it regulates sugar production. And if you don't, or regulates sugar levels and glucose levels. And if your body doesn't do a good job with that, then you got microvascular complications which result in eye problems, retinopathy, heart problems. You can get heart attacks, strokes, get kidney problems, nephropathy. You get problems with your circulation. You can't feel as well, resulting in amputations. And so managing diabetes is incredibly important. So in the type 2 diabetes, I think our endocrinology colleague can probably say, you know, it's not quite as simple as type 1 and type 2 anymore, but back in the day that was an easy way to look at it. But in the US, 95% of diabetes is type 2. So that's about, 30 million people in the US, maybe 10% of the adult population. It's a lot of people who have type 2 diabetes, and many people might not know that they even have diabetes, because sometimes it can be somewhat silent before it.
Nahi, so some years ago, I've been around a long time, longer than John. There wasn't a lot of diabetes. We didn't see a lot. When I see television reels and things from the 60s, we were a lot thinner back then. Can you talk to us a little bit about the pathology, diabetes, insulin, the pancreas, and some of that falls into your work and where we need to go?
Yeah, so diabetes, of course, as Dr. Wood said, we divide it broadly as type 1 and type 2, but he's right, there is a lot more different types of it. But it's basically one of two things. You're either not producing enough insulin, or your insulin is just not as effective because your body developed resistance to it. So inside our pancreas, we have the beta cells, which are the ones that produce the insulin. And they respond to the blood sugars. And the higher the blood sugar content in the blood, the insulin should go higher. And it works as basically the key to the gate to allow the glucose to enter the cells. Glucose does not enter the human cells very easily, so it needs to go through different ports, and the insulin is what allows it to come in. And then, for various reasons, obesity being one of them, but the exact mechanism is not always clear, increased obesity leads to increased or more problems metabolically with the sugars as well as the cholesterol, and of course hypertension and all the other factors. But it basically makes it more difficult for the body to respond to the insulin. So you end up having more and more insulin production, So initially you don't feel anything because the blood sugars are fine, but your insulin is getting higher and higher and higher until it gets to a point where it cannot keep up, and you start seeing the effect, which is the blood glucose now is high and stays high. And so sometimes we also have, or not sometimes we see the patients and we screen them because we're worried about their risk of diabetes, especially if they're obese or overweight. And they might not have diabetes yet, but they might have what we call pre-diabetes, which we can, it's basically insulin resistance, and sometimes it manifests as noticing that after you eat, the blood sugar goes higher than normal and stays high for longer, and also impaired fasting glucose. So even after not eating for a long time, like on your morning blood glucose, sometimes when you check and you find that it is higher than normal. And so I think also one of the reasons that we see a lot more diabetes is that we've been screening a lot more for diabetes compared to the previous years. And the definitions change based on how, where we think we can start targeting and helping people before complications start happening.
So, John, what are the numbers that make diabetes? How do I know if I have diabetes?
Well, there's a lot of different ways to diagnose it. Probably in the office, if there's an A1C, which is a hemoglobin A1C, and what they discovered was that red blood cells have protein on the outside of their cells that monitors your glucose levels. And if you can, and the turnover of a blood cell is about 120 days or 3 months, or 4 months. Sorry, my math isn't very good, so we'll call it 120 days. But if you can look at that A1C level, if it's over 6.5%, you have a diagnosis of diabetes. And impaired glucose would be anything over 6. Or you could do a random blood sugar, anything over 200. Or you could do a fasting blood sugar, anything over 126. So if you wake up in the morning and your blood sugar is over 126, and it's over 126 2 times in a row, and you haven't eaten anything, you have diabetes. If your blood sugar is if your A1C is over 6.5, if you do an oral glucose tolerance test, which is really not done very often anymore, where you give somebody a glucose load, say 75 grams of glucose, and then check their sugar a couple hours later, if it's over 200, that means you're not, as Dr. Kiblawi said, you're resistant to the insulin that you're making, because you should be able to clear a load of glucose and get your blood sugar back down to normal within a reasonable thing. The other way to diagnose it is if someone presents with signs and symptoms of hyperglycemia, like increased thirst, you're urinating a lot, you're losing weight, and they have a random sugar of over 200, they have diabetes as well. So there's many ways to diagnose it, Ray. Probably the important thing is to get diagnosed, and if you're concerned, is to come in. Like if you're overweight, if you have obesity, if you have risk factors, if you're probably less active than you should be, if you have high blood pressure, there's a family history of diabetes, if you have hypertension, heart disease, you're often going to be screened anyway. If you're a female and you have a history of gestational diabetes, you're certainly at an increased risk for diabetes down the road.
Dr. Kiblawi, when they say that I'm going to go to some questions now.
Sure.
When they say that blood sugars spike, what numbers do they mean? What's spiking?
Well, not very scientific term, spiking. We just basically refer to it that it's very high. And Now, one thing that people should realize, or most people should realize, that is that naturally the blood sugars after you eat should go higher. It just usually does not go beyond 200 after you eat, and usually by 2 hours, most of it has been cleared. So most people, it should be below 150 roughly after 2 hours. So if it starts staying longer than that, that's an issue. Now you have to keep in mind also how much did you eat, how much did you do. So these numbers are standardized based on, for instance, the glucose tolerance test. But if you ate a much larger meal, it will take you longer, much larger, specifically carbohydrates, will take you longer to actually clear that glucose. And that's why sometimes we have to utilize multiple different ways of testing before we figure out if someone is really diabetic or not, if they have diabetes or not. And the numbers actually change, depends on the situation, you know. So for instance, if you're elderly and more prone to having low blood sugars and have complications, we do tolerate higher blood sugars because hypoglycemia or low blood sugars is more detrimental to the health compared to the slight hyperglycemia or slight elevation beyond the normal. If you're pregnant, to protect the baby and the mother, of course, but also the fetus and the baby, we do actually use more stricter blood glucose measurements for control. So it's basically that depends on the situation. But generally speaking, yeah, you shouldn't be above 200 after you eat a meal. Although, again, some diabetics or patients with diabetes, especially type 2, will go beyond 200 frequently. The question is, with the treatments that we're giving them, are we allowing it to come down to where it should be?
So you both have wandered into gestational diabetes. Mm-hmm. So I do have a question on gestational diabetes. And this person is from here in town, asks, what are some of the risk factors for gestational diabetes? And this was a place where do you do continuous glucose monitoring? I know this is something you're interested in. And which one do you want to start on this?
Well, obesity for one.
Why don't you start?
Obesity would be certainly a risk factor going into it. Family history of diabetes would be another one for sure. You know, I'd say those two things. A prior history of diabetes, you know, in a previous pregnancy, of course, is going to set you up for gestational diabetes. That's why, but the reason, there's not so many things that actually, obesity would be the biggest one. That's why we screen people for diabetes in gestation. It's 26 weeks, because you don't have any way, there's risk factors, but you really don't. You've got to check everybody, because even someone who's slender and you think they really don't have any risk factors, they're very healthy, they exercise, et cetera, still too, they can be surprised that they are developing gestational diabetes because they're developing insulin resistance in pregnancy. And being pregnant is incredibly challenging endocrinological as well as physiological state, and so different people are going to react differently.
What does that do to the baby?
If you have diabetes and it's not diagnosed, or if it's not treated properly, it can lead to macrosomia, or a large baby when the baby's born, which can also lead to complications at the birth, like shoulder dystocia. Certainly it increased the fetus for all sorts of, I'd say the mom has increased risk of hypertension, but what we're really trying to do is make sure that the baby's born at a healthy rate to protect the fetus, certainly at the time of delivery as well.
Dr. Kiblawi, now, again, your interest is in continuous glucose monitoring. Is this something that we do in gestational diabetes?
Sometimes we have to, because sometimes, we're not sure, when we usually utilize the finger sticks and, of course, A1C. The typical diagnostic or screening tool is the oral glucose testing for patients who have not had diabetes before or had history of diabetes. On occasions, we do have to use continuous glucose monitor when the numbers are usually borderline, and we're not sure are they spiking in between, or how high is their blood sugar getting in between the finger stick checks. Because continuous, so it is used on occasions, but it's not part of the standard. Like we don't have to use it for most people who have diabetes, or for most people who have gestational diabetes. But there are situations where it comes in handy and helpful.
I'm going to change a little bit now. John, you brought up peripheral neuropathy, I think earlier it was you, I believe.
Yeah.
So how often should a person with diabetes have foot checks?
Well, they say yearly. You know, that's what the USTPF, the U.S. Physicians Task Force says. Typically, you know, in practice, I would recommend a little more frequently, like every 3 to 4 months. Certainly on somebody who has neuropathy, and neuropathy would be where, golly, I can't feel my feet as like I used to. They're kind of numb and tingly. Certainly if you have signs and symptoms of neuropathy, you need to let your doctor know. And the big thing about neuropathy is it can lead to undiagnosed injuries to your feet, leading to cellulitis or a skin infection. I've seen patients come in with thumbtacks in their feet. They didn't even know they had them, or pins in their feet that they've gotten. So I always advise people that have diabetes is to check their shoes every day, put their hands in their shoes to make sure there's not some object in there that they weren't aware of. But typically, you know, once a year in a doctor's office, but practically it's probably better to do it more often.
And the hard part is many people can't check their feet, so it'd be nice if someone at home could help them out.
Someone could help them, would be great. That's why it's a team sport. You know.
How, Dr. Kiblawi, how high does an A1C have to be before a physician should start a patient on insulin? And is that where we should start?
Well, again, that's a lot more
It's a big
complex.
question.
So
It's a big
type
question.
1 diabetic, patients with type 1 diabetes do not produce insulin. So really their treatment is insulin.
So the type
these
1 is the
guys-
young person that,
Well, traditionally we thought of them as the young
Young-
people,
now they're
and we
getting
used to
older,
call them. We used to call it diabetes of the young, but we realize now that a lot of also older people have diabetes that is type 1. So patients who have type 1 diabetes or diabetes due to immunotherapy or certain therapies that, or like pancreatitis or pancreatectomy, basically removing the pancreas or damaging the pancreas, so there is no production of insulin, you have to use insulin regardless of what the A1C was, because they just need it. Now, type 2 diabetes patients are a lot more complex, because we typically start with metformin for most of them, being one of the oldest, safest, cheapest medications that we have. And then we tailor the therapy based on their situation. And their A1C at the time of diagnosis does play a role. So patients who come in with a very high A1C, above 10 or 11, we're more likely to start some form of insulin on them. Patients who are more in the 7, 8, and 9, there's a good chance we can get them under control by just using oral medications or non-insulin injectables like GLP-1 agonists. So it depends on the situation. It depends on a lot of things. We've been seeing, more and more, whether through guidelines or through what we do, we try to target, because a lot of them have obesity, so we try to use the medications that would also help with weight loss. So GLP-1 medications have been used a lot more, and they keep getting used more and more often, because they, reversing the weight or causing weight loss actually can help reverse some of the diabetes. And if some people can keep that weight off, they might be able to get off of medications. So we usually target, in general, for all patients with all type 2 diabetes, a 7% to 10% weight loss. If they can achieve that, that would be ideal. And we also recommend, for just generally for glucose health use, is lifestyle modification and exercise. We do recommend 150 minutes of exercise weekly. And it doesn't have to be very intense. The intensity level is basically what's equivalent to a brisk walk. So if you take a brisk walk enough times in a week to get 150 minutes, that would be great. So it starts with lifestyle modification. That's why, and changing how many carbohydrates they eat, what types of carbohydrates do they eat. All of that affects their blood sugar. So it's, as I said, it's a lot more complex than just deciding that this is not this number and you go ahead and start this insulin.
my first prescription is 30 minutes walking every day.
Yeah.
No matter what's the matter with you.
Yep.
Bring it all the same. So this gentleman had an A1C of 5, and his physician recommended stopping all of his medications. Now, people sometimes will have a 10 or whatever, and weight loss and using medications, it will come down. Is there a point, Dr. Wood, where you would stop all of those medications or not?
I would seriously, yeah, 5 is certainly in the normal range.
It's pretty
yeah,
down
so
there,
that's
isn't
my congratulations to whoever phoned in. That's you know, a real
job.
success story there, and that means that they're following whatever recommendations have been given to them. Because yeah, there's a, as Dr. Kiblawi spoke about, the risk of hypoglycemia or low blood sugar is a real thing, and you don't want to take medications that you don't need. You can fall, break your hip, or worse, just by, you know, you could be driving and have a hypoglycemic spell if your sugars are controlled too tightly. And so those are things you really need to think about.
Sorry about the phone. I thought I had it off. Gastric bypass surgery, does that help with type 2 diabetes?
It does. It does tremendously help, and a lot of times the effect that we actually see on controlling the blood sugars is much earlier than even weight loss. So a lot of times, even going out of the hospital after their surgery, some of their medications are held, and again, it depends on how much weight, you know, were they at before they even start, what medications were they on, how good was their control prior. So it's not a one size fits all type of thing. So, but we tend to lower the medications as the patients are leaving, partially because they also don't eat as much early on. And type 2 diabetes, if you fast, you pretty much can get your blood sugars under control. The problem is none of us can fast that for that long. So you end up eating and then your blood sugars go up again. So that's why, again, we start with dietary changes, time of day, what you eat and all that. And the medications are really are secondary to help the blood sugar control.
So Dr. Wood, a gentleman with a slimmer frame, for example, and still, can that person still be at risk for diabetes?
Sure, yeah.
And is that more a case of diabetes type 2, or is that leaning toward?
I would hesitate to.
Well, you can both jump in on this.
Yeah, I would hesitate. I think we're probably at a part of our understanding where we're realizing that it's more complicated than just dividing it into 2 or 3 subsets of diabetes. Mm-hmm. Like, you know, there's mature onset diabetes of the young, where folks they've typically thought they had type 2 diabetes, but they still, or type 1 diabetes, but they really don't, and we don't really understand it as well. So I would say a slimmer person, Ray, that doesn't necessarily mean that they have type 1 diabetes. It probably means that they may not be making insulin, which is certainly predisposing you to type 1, but I don't think it's quite as simple as that.
Yeah, I agree. It's not as simple as that, of course. Even a lot of times we assume that someone, because they're obese and presenting with diabetes, that they're type 2. But then as we do more investigation and following them, we find that they're type 1, but what we call latent autoimmune diabetes. So these are patients who do have the autoimmune problem where your own body is actually destroying the beta cells and not allowing them to make insulin. But unlike what we typically see with the young kids, where it happens very quickly, and they end up getting sick very quickly and present to the hospital, unfortunately, most of the time. In those latent patients, it actually happens a lot more slowly. So initially, they might look like type 2 and just have resistance problems. Then you figure out, that they're actually not making enough insulin, and you have to go ahead and start insulin treatment. And there are also medications that increase someone's resistance or can cause hyperglycemia even in someone who's slim. So they will be somewhat like type 2 diabetes because it's an insulin resistance problem.
John, what is considered a good blood sugar reading? Where do you control to when you're treating a diabetic?
Oh, ideally below 126, 140. Really. But it's a little more nuanced than that, because in folks that are a little bit older, you want to have a little larger threshold. You can get away with a little bit more. But in a younger person, where they have their whole life ahead of them, and you want them to be successful and healthy, I'd say you're really looking for a sugar below 140, and then you're going to be able to get an A1C down. And you're looking at that A1C range. You're trying to target to an A1C below 7 is really what you're looking at. If you're thinking that diabetes diagnosed at a level of 6.5 or greater, if you can get that A1C around 7, you're doing a pretty darn good job.
Another question is, how much water should I drink each day if I have diabetes? Leave it open.
Enough not to be dehydrated, because that will differ. I mean, I cannot. If someone has congestive heart failure, we're going to have to be careful with how much they drink.
Yeah.
If they have liver problems or kidney problems, we're going to have to be very careful. So there is no specific recommendations to my knowledge there.
Yeah.
Generally, that feeling is to try to keep it where it's pretty clear.
Yeah.
Your light yellow,
Yeah.
or whatever.
Urine.
This has been a really interesting discussion. I'm going to have to bring it to a close. There were a lot of questions. You mentioned a medication. There's a lot of things that we could dive further into tonight, and this could go on for a long time, and it would be fun to do that. It's almost like a medical school lecture. So at this point, forgive me on the monitors. That one's not working. I want to thank our panelists, Dr. Nahi Kiblawi and Dr. John Wood, and our medical student volunteers, Sydney Boyke, Seth Kimball, and Lindsay Simonson. Please join psychotherapist Dina Kleibau next week for a special mental health program on addictions. Thank you for watching, and good night. Thank you, gentlemen, for being a part of this. Thank you, medical students. And I want to thank Linda Liskowitz for her work.